We're going to first start by discussing our admission forms. We're going to start at the very beginning. So we're beginning with a new client. When a new client walks through our door, they have a set amount of paperwork to fill out. That's when we get the client and patient information. This is where we have their information in the computer, and upon our first examination and our first interaction with the patient and the client, we just confirm everything. So we confirm that it is in fact a female rather than a male. We confirm that it is in fact spayed or altered or neutered. We confirm the history of the patient, so everything that we have in our system here. So under this patient, Ali, we have his name, we have the color that he is, his species, his breed, the sex, if he's altered, if he's unaltered, and then we have temperament as well as some other things. So we make sure that all of that is correct in the system, and that is going to be what we print out on our additional sheets. So all of this information that's in here needs to be correct. Upon the first client walking in the door, they'll be filling out a new client form. This new client form has everything from their information, how to contact them, emergency contacts if need be, and then it also asks for additional patient information. So not just the patient they're bringing in that day, but any other patients they have at home. This allows us to have an open line of communication and get those patients in the door as well should they need something. So at the very bottom, it also has treatment authorization. If this patient is ever under our care and something happens and the client cannot get contacted, this is giving us the authority to perform the services that are necessary. And then it's also asking about payment options, which again is opening up a line of communication to talk about payments and how we don't do any payments. They have to pay when the services are performed, so that there's no miscommunication. When we talk about our permanent records for our clients and our patients, we have everything online. So we have Ali pulled up here, and then you can see we have a few tabs. So our overview, again, is all of his signalement that we've already checked. And then if you go down to files, we'll have previous history. So a permanent record from all other clinics that he's ever been at. And then in our personal history, we have our consultations. So here we can see our personal history with this patient. The other forms that we use specifically for admission forms for a particular procedure, in this case we'll be using Ali. He's a boxer and he's going to be coming in for a dental procedure. So the first thing that we give them is their dental assessment consent form. This is specifically for dentals. This is giving us the permission just to go in and clean and to treat anything that we have previously discussed with the client. So if we know that there's an abscessed tooth, if we know there's a broken tooth, that's already in a treatment plan that we've sent home with them, and they're aware of those charges. This is giving us the agreement to go ahead and do that. From there, we also have an anesthesia consent form. This anesthesia consent form goes over in a little bit more depth, less so the procedure and more so the risks of anesthesia. It has date and time of last meal so that we can, again, communicate and make sure that they were MPO'd. A list of current medications so that, again, the communication is there. There's no way of forgetting it. There's no way that it hasn't been discussed. The procedures to be performed so that, again, the client is educated and there's that communication there so that nothing is unforeseen. And then the veterinarian doing the procedure. It talks a little bit about the risk of anesthesia and also about should unexpected life-saving emergency care be needed, what they request for their patient. So when I go into the room to discuss these forms with them, I simply go over our dental procedure. I go in and I confirm that they are in fact here for a dental cleaning procedure. I then go over their treatment plan or their estimate, which is in their file. And then going a little bit more into the back side of everything, so into our treatment room and into our staff communication, we have cage cards. This is the cage card that will go on the door of the kennel that Ali would be staying in. It has not only his name, but his approximate weight of that day, how old he is, his appearance, so liver and white spotted. He's a boxer mix, and he's here for a dental cleaning, and it also says the doctor's initials and the technician's initials. So if there's any question about this animal, they know exactly which staff member to go to in that situation. When we talk about laboratory forms, so initially when the patient comes back, we do pre-anesthetic workup, so pre-anesthetic blood work. We do all of that in-house, so there's no laboratory forms for that reason. But if we were to be sending out any specific tests that the patient might need, we do have lab forms. So when you add the test to the actual consultation, our IDEXX information will pop up a request form, and it'll have exactly what's needed for the test being performed. So it will tell us what serum or plasma or whole EDTA blood we need, and it'll also give all of the client or all the patient information we discussed. So it'll have their signalment on that sheet as well, and then it'll print out automatically for us and we package it with the blood. We do have these forms, so these are just paper forms that we can fill out. We don't use them very often. The only time we would use this is if we were adding or sending a separate sample to complete a pre-requested test. We would just add the accession number, the client and patient information, the doctor information, and send this separately with a new blood source if for whatever reason a test failed or we didn't send enough of a sample. So those are our laboratory forms.
For our anesthesia monitoring chart, we have something in our computer here. So we actually pull it up in the client's chart and it saves immediately to their consultation. But ultimately it just has the signalment of the patient. It talks about the procedure being done, the surgeon and the assistant. And then we also have our anesthesia chart. So our induction agents, the dose, the route, and the time that we gave it. And then we have our monitoring below that. So below our monitoring, we have a few different columns for us to put multiple time slots. So usually about every 5 to 10 minutes, we'll put in a time, and then we'll monitor the heart rate, the temperature, the respiratory rate, mucous membranes, or the capillary refill time, and then our SpO2 as well. So down below that, we even have our ISO percentage, our O2 flow rate, and then our thermal. So then at the very bottom, we have our anesthesia start and stop time, surgery start and stop time, and then intubation and extubation time.
This is our discharge sheet for our dental procedures. At the top, it talks about food and water, how much to feed that night. We do want to limit excessive food and water intake so that they don't vomit it back up. It also talks about if there's extractions to feed wet food over the next 2 weeks and to not allow the dog to eat that night, but instead wait until the morning. It talks about exercise and activity. We want to confine indoors into a crate until about 24 hours until all the anesthesia reactions wear off and the dog's a little bit more capable of maintaining its temperature, regulating its temperature. We don't want them to just be taken right back outside into 100-degree heat. So there's a little bit about exercise and activity. Eliminations, it notes that constipation can be normal. I'm going over all of this in the room. I'm not reading it off of the page, but I'm simply talking about it and kind of noting down to the paper saying it's all here for you to read at home, but this is a time for me to really eye to eye tell them all of these things. And then we're also monitoring for lethargy, weakness, really not wanting to get up, really not acting like themselves, not wanting to eat or drink for 24 hours, and then severe vomiting and diarrhea. We want to know about that immediately if any symptom like that occurs. So we warn them to call us if they notice anything abnormal. We have a little bullet point for medications to go home. There's a few different types: pain medication, anti-inflammatories, antibiotics, and it all allows us to write it out and write the instructions out even though it would be on the bottle for them. It's just a quick reference guide, and if there's any more instructions like we need to start this on the next morning or we need to start this the night of the procedure, all of that would be written here as I was telling them about it. We also have appointments, a medical progression exam. If we need to set one for rechecking an extracted tooth, that would be written down here, and we would tell them to set that up with our receptionist, and they would again give them a reminder card. And then special instructions at the bottom. We also have a little disclaimer that due to the intubation tube, coughing is normal for about 24 to 48 hours, but to call us if it seems severe or if it seems to be bothering the patient. At the very bottom, I write my name and I sign my name, and it says right there technician name, so that if they call with any questions, they have somebody that they can request to talk to. But that is our discharge paper.
As a clinic, we also have a few other unique forms. So not only do we have specific forms or consent forms for every different procedure we do, we have different discharge forms as well. So down here you'll notice that we have boarding consent forms, dental cleaning assess and cleaning consent forms, our discharge forms, our euthanasia consent forms. We have social media consent forms. Everything that you could think of is going to be underneath this client's forms file. So we can go and choose any one of these, and it's going to be specific for this patient. So not only are we doing benefits of neutering your dog, we have our euthanasia consent forms, our patient check-in sheets, and then even our boarding consent forms. So everything, you can see it automatically pulls this client and patient information in here, and it goes through all of the consent forms we might ever need for this patient, and they're all at the touch of a finger. So those are our unique client consent forms.
Relatively hyper dogs that like to push out is I just make sure that my hands grasping their thorax before I open the door so that they don't die while I'm out. And then I just pick them up and carry them to our exam table. If he was an aggressive dog, we would have to do something a little bit different with him, like apply a leash around his neck and then direct his head away from us while we grab his back end or even throw a towel over him. But for a nice dog a saphenous hold, what you're gonna do is you're gonna roll outward, so this way, towards the knee, and then that will allow our saphenous vein to pop out, and we will be able to isolate it and pull blood from that as well. And so that's how you would hold for a saphenous draw. A few different holds as this dog's falling asleep on how we would pull blood. So with our cephalic draw, we are going to push this elbow forward and then roll our vein outwards so that this cephalic vein is open and available to the person drawing the blood. And then of course we could also have them ventrally, but all of the same parameters apply. You just twist and hold off until the blood has been drawn. And specifically for a jugular stick, we will be removing a collar. I like to hold on these front legs so that he can't kick or rear up. And then I simply take my elbow, since I have a pretty small arm, underneath and direct that way. That way the technician can get underneath my arm and have access, full access to the jugular vein, and I have very good control over the head. Now if it's a smaller dog, you can simply take the head alone, but sometimes they like to rear up and kick. I prefer to be able to control the legs and the head at the same time. Other times, often you can simply control the head by the muzzle, but I think it's just gentler and a little bit more comfortable for the dog to go underneath and just make sure that elbow's popped up a little so that the technician can get access to the vein. So what we do with an aggressive dog that needs to be muzzled is we have our assistant holding the leash directly above him so that he isn't able to lunge at me. And then I come from below his head and I come from below his head and I wrap the muzzle around, and then I'll loosen up this leash so that I can get it buckled behind his ears, and I just make sure that it's tight so that it's not going to slip off and his ears are out. And that's how we would apply a muzzle. Okay, so this is Hudson. He's getting sedated in our room today. We're also planning to use a little bit of anesthesia. So he's getting a basic TPR, pre-anesthetic workup, the same as any other patient that's going to be going under sedation or anesthesia. So I like to start at the nose and then kind of go from there. But first, we're just going to get a basic TPR. So our temperature, my thermometer is coated with a little bit of lubricant. And then I just insert that into the rectum. And with cats especially, you sometimes need a hand to hold them still. And then I'll allow that to beep, and a normal temperature for a cat is anywhere between 99 and 103. And then at this time I'm also feeling for the femoral pulse on the inside of our leg. And I'll look up at my clock to see what our pulse is. Also going to be paying attention to the breathing, so our respiratory rate at this time. Again, I'll be feeling and counting for the breaths per minute. So again, I'll look at my clock, calculate that. And our temperature is normal at 100.4. I'll also listen to his heart and lungs at this time. So I'm listening right where his elbow would meet his chest. I hear a steady, strong heartbeat without any signs of murmurs. I also want to line it up to his femoral pulse to make sure that there's no deficits there. I'll listen to the other side. And then I'll focus on our lung sounds, making sure that our lung sounds are clear. And he's purring quite a bit, but when he stops, I'm able to hear a little bit in between. No crackling, full breaths. So I would say that that is normal. No deficits like I mentioned. And then from here, like I mentioned, I like to start at the nose. So I'll note any abnormalities at the nose, any drainage, the eyes, make sure that the conjunctiva is white and not red or bloodshot, that our pupils are dilated appropriately. I will look at our teeth, if we have any deciduous incisors, broken teeth. I'll also open the mouth and see if I can isolate the tonsils. This is a wonderful cat and opening very wide. And then I look into the ears. These ears actually have a little bit of discharge in them, and the owner mentioned some shaking of the head, so later we'll probably want to swab those ears but it is something abnormal to note in our chart. I see a little bit of hair loss around the eye as well, so it makes me think that this cat's been itching right here at its temples, which would also line up with an ear infection. From there, I feel the lymph nodes. This cat's lymph nodes are slightly enlarged. I think that it might be due to the fact that we might have some sort of yeast infection or irritation, inflammation in our ears. And then I check our paws. We are declawed, our pads look healthy. Hudson, you're doing so well. And then I just check the skin. So I'll check the skin behind the neck, anywhere that fleas or ticks might be hiding. I'll just overall feel through skin for dry flakes, patches, and again fleas. And then any abnormal masses. I also want to try and feel for those. And then I'll turn him around. I'll take a look at his back end a little bit closer, his back paws. His scrotum, as well as his belly. I'll palpate. In this cat, I can feel a bladder, so that's important to note if we're needing a urine collection. He's not rigid, he's not stiff to the touch. He's allowing me to palpate easily, and I don't feel anything abnormal aside from some extra poop in there. I know it, I'm sorry. From here, I will assign an ASA grade. This cat is only 3 years old, and he has not had any long-term illnesses. We do blood work on this cat pretty regularly. We've seen it since it was a kitten. He's up to date on all of his vaccines. FIV, FELV tests have been negative from a kitten, and we've done vaccines for him. Overall, I mean, we have a really good history with this cat. We know him well. I would assign him a class 1 slight risk for this procedure, considering we won't use very much anesthesia at all, and also considering it's just a grooming procedure. I think that this is a very minimal slight risk patient, and everything else that we've done today lines up with that. So assuming that our blood work comes back normal, he would be a class 1. For our saphenous vein, our assistant is going to roll outwards so that the vein can be isolated. And what I'm doing from here is I'm isolating with my thumb. And stabilizing. And then I insert my needle with the bevel up, and I withdraw slowly on the plunger until I get my needed amount of blood. You can also pump the foot a little bit if the blood flow is rather slow, and then my assistant will let up as I pull the needle out and pull it off on that injection site. Isolate our vein, and then once I have that vein isolated, I will insert the needle with the bevel up and withdraw slowly, and I can pump the foot if the blood flow is rather slow, and then my assistant will let up. I will hold off where I pull the needle out, and that is blood for a cephalic draw. To do jugular draw on a canine patient, what we're going to do is insert our thumb at the thoracic inlet as our patient holds the head up and at a slight angle to the right. I will use my alcohol to isolate the vein, and once I feel that, I will insert my needle. Sometimes if the vein is hard to feel, readjusting the head slightly will help that pop out. And then once we have it isolated, we'll insert our needle with the bevel facing myself and pull back on our plunger until we have the needed amount of blood, and then we'll withdraw, holding off, and insert into our tubes. We're doing a cephalic draw on this feline patient today. I have my assistant holding off while I isolate the vein. Once I have it isolated, I'm going to take my TV syringe. We usually don't do blood draws for large quantities of blood out of the cephalic, just because we don't usually get a lot. But I'll insert my needle hub and pull out about half an ml, and my assistant will hold off, or let off, and then hold off on the vein. I'm using this for an FIV, FELV, so it immediately goes into a sample cup. But this is about the quantity that we would get from a cephalic cat vein. If we needed any more blood than this, we would likely use the jugular vein instead. But this is enough for this test. Get the bevel up. And when I get my flash of blood, I will slowly pull the plunger back until I have the sample that I need. I'll hold off and then have my assistant hold off where I am while I insert my blood first into my EDTA tube so that it doesn't clot, and then into my serum separator. And I will rotate the tube so that it'll get coated. Databases for our patients in our facility are very similar to those in the tier book. However, we just simply do a CBC as well as a Chem10, so there are some additional factors that go into that. Our first minimum database is the PCV, the packed cell volume, or the hematocrit. So what this is going to show us is going to show us the percentage of red blood cells that make up our total blood cell volume. If this, for whatever reason, is low, if our red blood cell percentage in our blood is low, it's basically anemia. Now, where this anemia is coming from, we need to figure out whether it's autoimmune, whether it's due to trauma, due to some area of the body that's collecting a lot of our red blood cells, like a mass. And then if it's high, if we have a lot of our red blood cell concentration and little of anything else in our whole blood, then we would be concerned with dehydration predominantly, which is pretty a common thing to find. So those concentrations are important to note before we do anesthesia, because that can affect the way that our anesthetic gases are processed. From there, we have our total protein. Our total protein is showing the concentrations of proteins in our serum, from our globulin, our albumin, to our fibrinogen. All of those serums are calculated in this total protein. And then from there, we're talking about if we're high or if we're low, what that could mean for our patient. The lower the TP value, that means our oncotic pressure is a little bit lower than normal as well. And what that basically means is that it's going to affect the way that the fluid moves between our patient. Our blood glucose is our next part of our minimum database, and that's basically letting us know the glucose reading in the blood. This is important if we're hypoglycemic or hyperglycemic. We need to know this before a procedure. It lets us know how our enzymes are functioning and kind of how our pancreas is doing as well. This is just a basic run-of-the-mill test that we need to do before any surgical procedure. Our BUN, or our blood urea nitrogen, that's reading the nitrogen that's building up in the body. If we have a higher level of nitrogen building up in the body, then our kidneys might not be functioning properly. And if our kidneys aren't functioning properly, then we have an issue with our anesthetic gas as well. So that's important to note. If our kidneys aren't properly functioning and filtering out the anesthetic gas, that would be a problem, because it would then build up in the patient and we could have complications. So if our BUN is high for any reason, we need to know why, and we need to know what we need to do to fix that situation. Finally, our ALT is kind of our liver functioning test. We use this a lot when we're also functioning or testing for drug reactions. So when a patient's on long-term NSAIDs like Rimadyl, this is a part of our blood monitoring profile as well. If the ALT is high, it's an enzyme that's excreted by the liver, and it could be due to damage, trauma, something similar to that. So if that ALT is high, we know that our liver is having an issue, and we need to kind of figure out where that's coming from, because again, it can affect the way that the anesthesia is, processed. Additional tests that might be needed if our previous tests were abnormal, or if the patient is just exhibiting abnormal symptoms even without needing a surgery, we would talk about additional tests. So anything from radiographs to fecal flotations to CPLs to T4s, all of that could come into play depending on the symptoms that we see. So with a blood monitoring profile, we're checking our ALT, we're checking our BUN, we're checking a few different levels on a Chem10 that we would run just to make sure that everything is normal, the patient isn't exhibiting any abnormal symptoms, and we also run a CBC. That's just a basic run-of-the-mill test. Now, if somebody comes in, they're on Rimadyl long-term, we're needing to do a blood monitoring profile, but they're also vomiting up blood, they're having bloody stools. At that point, we might need to talk about doing some additional testing. So it's not just our baseline anymore. Fecal flotations, additional blood counts, additional Chem17, some extra some extra tests that we throw in there, that might be necessary. And then we also talk about when we have a puppy that comes in that's sick, we have our parvo tests, we have our stool tests, we have our CBCs and our chems to see what kind of medications and what kind of fluids are necessary, because we need to know where this puppy's body is reacting to this illness, and we also need to figure out what the illness is. So not only are we running our basic chemistry and our hematology to make sure that we're appropriately treating the symptoms that we're seeing, we also need to know where this is coming from. Is it truly parvo? Is it giardia? Is it some other form of parasitic infection? Or is it something completely different? So additional tests are sometimes needed and necessary and indicated by the doctor during particular procedures. In our clinic, we use usually the same list of inducing agents as well as antibiotics, anti-inflammatories, antiemetics for our surgical patients. It's usually steady and stays the same. If you were to look at our surgical consent form and treatment plan for a spay and a neuter and a dental, it would have all of these injections in there listed out so the client can see the value. The only time we would differ from this if it was an extreme case, if we needed to be concerned about health risk or a geriatric patient or a particular procedure that's high risk. That would be when these things might change slightly, but for the most part we use this same set of pre-anesthetic and peri-anesthetic protocols. So what we start out with for our induction agents are usually a mixture of Domitor, ketamine, and butorphanol. You mix that into a single syringe and we give it IM. It has about a 15-minute onset, and then at that time the patient's pretty well sedated. Sometimes sedated enough to take off a dermal mask or put in a few sutures, but usually you then have to add on our anesthesia gas on top of it so that they're completely anesthetized for full surgical procedures. But that's a good sedative that we like to use. It allows us to intubate appropriately, do very minor procedures, and then just induce further with our anesthesia gas, and it keeps them calm and relaxed, but we're not wrestling them on the table with a mass induction of a completely awake patient. From there, we talk about antecedent. Our antecedent reverses the effects of the Domitor, so it's also very safe in that fact because we can reverse it if we need to. We simply take them off of the anesthesia. We give that reversal either IV and make it very quick, or IM and let them wake up a little bit more slowly, and they're back on their feet in a shorter amount of time. So we love the fact that we can reverse this protocol. We also have our penicillin. We use penicillin on pretty much everybody unless there's an allergy, or if it's an intensive procedure like an orthopedic or Pymetra or something along those lines. We use our convenient injection every time. We also use Buprenex or butorphanol. We also use Buprenex or buprenorphine regularly for our analgesic factor. There's some analgesic properties in our DKB, but not enough to really help with the pain of the surgery. So that's where we add in our buprenorphine. And then we also have an anti-inflammatory. Rimadyl is our anti-inflammatory of choice. We use that on dogs, and we have Onsior for cats. And then for Cerenia, we do our Cerenia injection well before the procedure starts, usually when we're prepping the patient with our IV catheter. We'll go ahead and do that injection so it has time to settle, and that's our antiemetic that keeps them from getting nauseous or vomiting during the surgery or after when they're waking up. So that's our baseline procedure. We also have a few other things that we might give here and there, but that's our basic pre-anesthetic induction therapy. For Clio Bomber, we have our controlled drugs as well as a few other drugs that are on this slip. We are going to add the controlled drugs to our drug log. So we used butorphanol. We used 0.4 mLs of butorphanol. I'm going to find that in my drug book, and then I will add it to our list. So we already have one full page of butorphanol. I'll go to the second page, and then under date, I'll add the date that we gave this medication. I'll also add her name as well as the client's name. She is a canine. She weighed 75 pounds. I add my initials since I'm the one that took it out of the safe, and then I will add the amount of the drug that we gave, which was 0.4. There is no milliliters wasted, so I'm not going to add anything to that line, and then I subtract from the running total that we had of 35.65, and I take out the 0.4 from that, which will leave me with 35.45 or 25. And then of course I can always use a calculator if I need to double check. But that is how we would add to a drug log. When discussing our anesthesia machine, we first start with our oxygen. Our oxygen is a large H tank that's stored in an isolated area, and that tank gives us oxygen to our entire clinic. We have multiple ports throughout our surgical suite, our radiology suite, and our treatment area, as well as our isolation suite. The high pressure hose that's coming from the wall is actually giving us the oxygen we need into our machine. So at the back of this oxygen flow meter, that's where the oxygen is being fed. We also have our flush valve. So this is a way of adding high pressure oxygen directly into the system if ever needed. It's also how we are able to check our leak tests and do all of that and flush our system. If you turn this valve to the left, this ball bearing will go up and down, and you will put it onto the appropriate measurement for the patient, which is always by weight. And then from there, our oxygen flows out of this hose and into our vaporization chamber. So this chamber here is where our isoflurane liquid is housed, and it mixes with our oxygen and turns into an inhaled anesthetic gas. That inhalant comes out of this tube here and then goes into the back of the machine, where it comes through our inhalation valve. So this unidirectional inhalation valve allows the patient to breathe in but not exhale air back into here. It will only exhale over in this unidirectional valve. But that anesthetic gas comes through this hose and directly into the patient at the intubation tube, and then that patient is then able to exhale all of that anesthetic gas plus the CO2 that is being produced by the patient into a few different places. The first place that it goes is down into our soda lime canister. This is our CO2 absorber. It does need to be changed out regularly. We have our date here so that we know the next time we need to change it. This is a way of creating rebreathable air and gas. So it takes that CO2 out, and then the patient's able to rebreathe some of it. So that's one of the places that it goes. Another place that this exhaled CO2 and gas goes is into our reservoir bag. This reservoir bag starts to build up pressure, and then you can use it to breathe for the patient as a way of giving the dog or cat a sigh, and just as a reservoir of anesthetic gas. It will then go through, if you were to squeeze this and give it back to the patient, it would again go through your CO2 absorber so that you're not pushing CO2 into the patient. And then another place that it goes is down this tube into our passive waste system. And our passive waste system is a charcoal canister that is kept at a lower gravity so that gravity can kind of pull it down. But that's a way for any excess gas and CO2 that's not going to be able to be reused to exit the system without damaging people in the room by emitting the gas and the CO2 into the air. We have a few different valves and gauges on here to go over. The first one is our pressure meter. This is reading the pressure in the system as well as in the patient. So if this was hooked up to a patient, it's not only reading the pressure here, but the pressure in the patient's lungs. So it's important to pay attention to this and make sure that the pressure isn't getting too high as to damage the patient's lungs or inhibit them from breathing. And then we also have our pop-off valve. Our pop-off valve is a way to relieve pressure from the system. So if this is hooked up to the patient's lungs are the only thing that this air is going to. If this was closed all the way, the pressure would build up, this number would skyrocket, and the patient could potentially get some harmful side effects. You do close this to do your leak test, but this is just a route out of the system. Now, if I close this all the way and this is just open to the air, the pressure wouldn't build up because this is the second place that the pressure of the system can escape. But if it's attached to a patient, that patient is going to be where all that pressure goes, and there could be some damage that gets done that way. Ultimately, that's our anesthetic machine, and then from here we'll talk about maintenance. We have our cuff syringe. We always keep this on our anesthetic machine so that we can inflate and deflate our cuffs quickly on our intubation tube, so that if a patient wakes up without warning, that this is always going to be available to deflate and pull that intubation tube out. And then we also have the chamber down here. This line lets us know when we need to refill our ISO, and this is the chamber where we refill it. And then, like I mentioned, we do have to change our CO2 absorber or soda lime out regularly, as well as replacing the charcoal canister down at the bottom. So that's a little bit of maintenance there, and then ultimately these tubes will just get cleaned after each patient. With a non-rebreathing system, so our regular rebreathing system is a pretty large component. There's a lot of heavy breathing that needs to happen in order to use these unidirectional valves. So a pretty large animal would need to blow into this with enough force to force all that air out into the exhalation valve and then inhale fresh new oxygen and gas out of the inhalation valve. So with a system this big, it's hard for an animal under 5 pounds to be able to do that appropriately. So what we do in that case is we actually switch this out for a non-rebreathing system, which we actually had to return ours recently because the pop-off valve had an error and we haven't got our new one in yet. So I'm going to show a few different pictures, but basically what you do to set that up is you're taking out all of the components that make this machine work. So your soda lime canister, or your soda lime, CO2 exchange, and your pressure valve, as well as your pop-off valve. None of that's working with the new system that we're attaching. This is where our ISO oxygen mix comes out, and we actually remove this. And that's where we would plug in the valve or the hose for our non-rebreather. So it's actually taking out all of this here. So this part of our anesthetic machine is just no longer functioning. We have our oxygen, we have our oxygen coming out of the wall into our gauge and then down into our ISO and turning it into a breathable gas. But from there we have something else. And I have a picture of it here, and I'll make sure that it's in frame. So our picture here, what we have is we have our bag, so our reservoir bag, instead of our normal reservoir bag, it's actually attached at this point down here at the end, and then this hose is where our ISO and our oxygen are flowing into. So this end here is actually what's attaching down here, and then that ISO oxygen is breathed in by the patient all the way here. This is our mouthpiece that attaches to our endotracheal tube, and then as they exhale, they're exhaling into this. And this tube here is attached down here to our reservoir bag. And then this is our new pop-off valve that's again attached to our charcoal container. So I have my anesthesia machine hooked up to our oxygen supply, which is coming out of the wall. I have rebreathing tubes as well as our reservoir bag attached so that we can go ahead and do our leak test this morning. What I'm going to do to start our leak test is twist this pop-top relief valve. So I'm closing this valve. If this valve stays closed, it will interfere with our patient. So our patient won't be able to expel excess gas and it will build up and the patient would ultimately suffocate. So knowing that that's closed and knowing to open it back up and to check for it before surgery is really important. So now that that's closed, there's not going to be, if I block off this with my thumb, there's not going to be any, or there shouldn't be any air that comes out of the system, and this will make sure that we don't have a leak going on. If I plug this well and I turn my oxygen on and it lowers, then there's somewhere in this system that there's air coming out of, and that would be a problem. So I have everything hooked up, I have my oxygen on, I hit my flush valve until I reach 20 psi, or a pressure of 20. So once I'm at that pressure of 20, I'm holding off, and as you see, that gauge isn't going anywhere, so it's holding steady. Now that being said, I feel confident that we don't have a leak. Now because my thumb is rather small, occasionally I'll see a slight drop. Like right now it started exactly at the 20, and it's maybe a fourth of the way down to 19. So that's a very, very slow leak, and it's probably due to the fact that I have a small thumb and there's air escaping from that. But as long as we've been talking right now, this hasn't reached below 19. That's a sufficient leak test. I'm now going to relieve my pressure without letting up on my thumb. I let all that pressure go, and then I release my thumb, make sure my oxygen's off, and that's our leak test. For the induction of anesthesia with our surgery room, a few of the specifics that we have to have in order to induce a patient is our anesthesia machine with our appropriate size tubing and reservoir bags. We have our oxygen supply, which is currently in the wall. That also has to be turned on. And then we get to kind of our table where we're actually inducing or maintaining the anesthesia. We have our tie downs for all 4 legs. Depending on the surgery, we have to have them placed on the table appropriately, and these help in the case of if the dog was to ever wake up. It also helps, again, position for the appropriate surgery. We have our surgical packs, which we normally have an instrument tray, but it's being used in our treatment area right now. Aside from that, we have our endotracheal tubes. We have our endotracheal ties so that we can appropriately tie it to the animal's head. We have our laryngoscope so that we can accurately see inside of the patient's throat while we're placing that endotracheal tube. We also have our monitoring equipment. We'll have a bear hugging warmer and then a heat reflecting mat that will help keep the patient warm. Overall, that's kind of what's necessary to perform a induction for surgery. And then we also have a sling over here. The sling for Bernie is to help move the patient from the treatment area into the surgical suite. For a large patient, if we had a cat or small dog, we would just sterilely move them by supporting their weight. But this is for our large dogs. But overall, that's what we would need. We also have appropriately sized masks and rubber sealants so that we can mask induce our patients if necessary. We have all the multiple sizes up here, which is a double cabinet that we can access from the surgery room as well as the treatment area if we were to need it in there. While our patient is going to sleep, it's a good time to talk about our sizing of our intubation tube. So the size of the intubation tube varies depending on the size of the dog. What I like to do first is measure the diameter of the tube itself to the diameter between the nostrils. If that lines up, it's usually a good fit down the trachea. And then you also have to measure down towards the apex of the heart. So you just kind of have to understand where this is going to lie. We want it to lie above the apex of the heart, so about this length. So down to this 20 is where I want to tie it off. I'm going to finish up by shaving so that there's no hair stuck in the tape when I take in the catheter. You want at least an inch or two so that the entire catheter is free of hair and the tape's easy to stick onto the patient. And from there we do a quick scrub of alcohol and chlorhexidine. I'm sorry. Once that scrub's done, we'll start applying our catheter. So from this point, my assistant will hold off on the vein, and then I'll isolate the vein in between my thumbs, pushing it slightly medial. I have my catheter. I'll place the bevel up and insert into that vein until I see a flash, and then I will go just slightly more and start pushing my catheter off of my needle. My assistant at this point can now let off as I pull out the needle and place my plug. And from here, I'll tape off. With a patient that likes to move quite a bit, I like to place my first piece of tape just over the whole catheter so that I can make sure that it's in. And then from there, I'll clean up the little bit of blood that I got and place it a little bit more stable. But I like to get that piece of tape down so that when she's jerking back and forth, the catheter is not falling out. And from there, I can clean up the little bit of blood that I got on the patient. From here, I will place a piece of tape, sticky side up, underneath the catheter and roll it over. And that will keep the catheter pushed up into the vein and stabilize it a little bit better. And from here, you're just keeping this IV in place. So once I have those pieces of tape, I will apply my ret wrap. Making sure it's patent. I'll insert my flesh feeling for the vein as catheter with a little bit of heparin. I can feel the flush moving through the vein up above the catheter, and then I also don't have any fluid displacement outside of the veins. Bevel up, I wait for my flash, which I can now see. I push forward the catheter while pulling out on the needle. I place my thumb over it so that it holds its place. And then I place my plug, and as you can see, the blood's flowing through the catheter. And from there, I will tape it in place. I will initially put one large piece just to hold it in place, since this cat's a little squirmy and it could move at any moment. I apply that top, but not too tightly, and then I'll go in and apply underneath that plug to push the catheter up so that it doesn't fall out. And then I reinforce the top and the bottom with additional pieces of tape. And finally, a piece of that wrap. To make sure the catheter is placed properly and is working appropriately, I simply pull out on the leg. I hold off to where I can still feel the vein with my thumb. I have a little bit of heparin and just sodium chloride, and I pulse it slightly until I can feel it in the vein up here, which I can feel every time I pulse that fluid moving through the vein. And there's also not any sort of hematoma or odd bump where the fluid would be displaced outside of the vein. So that's how I know that this catheter is appropriately placed. Silas, our dental for the day. What we're doing now is actually prepping him for his dental procedure. We're going to be doing it here in the treatment room, but this is where we'd also prep for our surgical procedures before you move them into surgery. He had a mixture of DKB, Domitor, ketamine, and butorphanol about 10 minutes ago. And so we're letting that take effect. We're going to pre-oxygenate by giving him a masked oxygen load for about 5 minutes. Our ISO is completely off. At this point, we're just letting him breathe the oxygen. We're also allowing the DKB that we just gave intramuscularly to continue to work. We'll do this, like I mentioned, for about 5 minutes, and then once that 5 minutes is up, he'll be even sleepier than he is now. He'll be a little bit more sedated than he is now. We'll turn on our ISO and mask induce just a little bit until his reflexes are a little bit slower and we're able to intubate without trauma and without irritation. So now that he's been on oxygen for 5 minutes, we're going to mask induce. We're turning on our ISO with the appropriately sized mask cover to prevent any gas emitting, as even though mask induction, there is a lot of gas that is lost into the room. We're trying to prevent that as much as possible. So our mask is tightly sealed with this rubber seal, and we will let this dog go to sleep a little bit more. And once we don't have palpebral reflexes and he seems to be sedated, we will go ahead and intubate. To demonstrate our sub-Q injections, we're going to use penicillin as our sub-Q. So I take a pinch of skin above the shoulder and I make a triangle. And so at the base of that triangle, I'll insert my needle, aspirate to make sure that there's no blood and that there's negative pressure. And then I insert the drug. When doing our induction with, let's say, Tilazol or another IV medication, We have our animal that's prepared for surgery. We use alcohol to scrub the site of the injection, and then I'll have the assistant hold off on the vein while I palpate it and isolate the vein. I will then insert my needle with the bevel up into that vein until I get my flash, and then I will make sure that I get my flash into the syringe and then slowly inject as my assistant lets up, and then I hold off on the vein itself, and the patient will quickly fall asleep. We prefer to use the IV catheter to do our IV injections of our inducing agent. So we would make sure that the catheter is patent, and then we would insert our injection, and then from there we would flush it through the catheter. And that's our preferred route, but that's another way of doing it. So we have our DKB. This is an intramuscular injection. It's going into this back quadricep or gluteal muscle. What I like to do is isolate the gluteal muscle. I can feel the two muscles where they connect. I put my thumb there so that I can isolate that gluteal muscle, and then by doing it in this gluteal muscle, I know that I'm not going to hit the sciatic nerve. I know that I'm not going to hit a large artery or vein. I will aspirate regardless. So I insert my needle into that gluteal muscle, I aspirate back, and then I inject. And it does sting a little bit, so I expect him to react some. And then I pull out. My assistant will open up the mouth behind the canines, and then I will reach in and grab the tongue. I will pull slightly at the tongue so that the jaw opens, direct my light down into the esophagus and trachea area of the dog. And then I'm looking for my epiglottis, which I fold down with my intubation tube. And then I slide the intubation tube in between the laryngeal folds. I heard a little bit of air escaping from the endotracheal tube where the dog kind of hacked, and that's a good indicator that I'm in the right spot, but you will never be in the right spot unless you see it actually go through the fold. So if you don't see it, it's not in, but there are a few ways to make sure, and that sound that I heard is one of them. Now I'm going to inflate my endotracheal tube cuff with the cuff syringe that I keep on my anesthesia machine. I inflate it to where it's bouncy. I can give it some, it has some give to it, but it's still fully inflated. I also try and hear for air escaping around the cuff. So if I can hear all of my air escaping from the actual port and not around the cuff, I'm pretty well inflated, but I don't want this to be so tight that there's no give, because then it's probably a little too tight in the patient. And then I will just simply attach and turn it on, turn our ISO on, and then turn our oxygen on per patient weight. And that is how we would intubate a patient. Okay, we are prepping for not only a neuter, but also this cat is a cryptorchid, so we're prepping for an abdominal incision as well. So I'm going to pluck the hair at the testicles, and then I'm also going to shave from our sternum down to our scrotum. So I'll start with that. And you want to use your clipper blades in both directions to get an adequate closeness to the skin. And then I like to make this line as straight as possible by holding my clippers upright so that it looks clean to the owners. Okay, I'll just put maybe a little blood on the face as you can see there. And then I go down in the other direction to again get as close as possible. Solution and an alcohol to rinse it with. So we start with our chlorhexidine right at where we would do our incision, and then we move in a circular pattern outwards, never to touch that central position. And then we rinse with our alcohol. And that is what we consider one scrub. We'll do that a total of 3 times. And I'll also scrub the testicles separately. Do our final scrub.
Do you know how far out A. Smith is from being done?
And the surgery room, so that during transportation, if there's any contamination, we have a final scrub. For a patient that we believe is going into cardiac arrest, we have a few different, preferably we have 5 people on the team helping. 1 to assist with the ambu bag, 1 person to pump the chest, and then 1 person to document all of the life-saving treatments that we are describing, 1 to monitor the femoral pulse, and then the doctor telling us what medications we need. If we believe that we're in distress, we would immediately turn off our vaporizer, and then we have our ambu bag that we would attach to our endotracheal tube. The ambu bag is the second priority to the chest compressions. Our chest compressions on a patient like this, you would put your hand underneath the chest and then your thumb basically where the elbow meets the rib cage, and then you would pump 1 to 2 times per second, and then you would continue that indefinitely until life-saving measures were no longer needed. Your ambu bag is secondary, and that is going to be pumped by a second assistant every 10 seconds. If there's only 1 assistant doing both, your chest compressions are put as a priority over your ambu bag because there's going to be gas exchange through the pumping of the chest. With a larger dog, you would use your palm and something hard underneath the other side, but for a cat, your thumb and your forefingers underneath the chest. From there, life-saving medications can be administered, and then hopefully your patient begins to breathe and have cardiac function on its own. So now that our patient is scrubbed, I have unattached it from the tube so that during transportation, our trachea doesn't get damaged from movement of the endotracheal tube. I will support the patient without touching the surgery site under the head and pelvic bones and transport it to surgery. With a larger patient, we would use a gurney, but for a small patient like this, this is adequate. And then our tubes are now in our surgery suite. And then we will just position our feline patient and reattach it to our anesthetic gas. You like to loop the ties around the hock and then do a double loop around the leg so that no part of the leg is being pulled or too much tension is being put on a single part of the leg. We'll do that for all aspects. And then once we have him positioned, we'll hook him up to his leads, do his final scrub, and drape him. Now that we are connected and hooked up to our monitor, I will do our final scrub, which will include 1 more pass of our chlorhexidine and another pass of our wash, which is our alcohol. At this time, I will now gown up sterilely and do the final draping of the patient in preparation for surgery. A graph which is attached from the tubes, our inhalation and exhalation tubes from our anesthetic machine, all the way to our endotracheal tube. What this is doing is it's measuring the CO2 that the patient is expiring, And then we also have our specific SpO2, which this is measuring the oxygen concentration in the blood. We put this on the tongue or another fleshy part, sometimes the ear, and sometimes even the vulva would work. And then we also have our esophageal monitoring EKG probe. Now what you have to do with this is it does run down the esophagus, not the trachea. So I already have my tube set in my trachea. What we do with this is we measure to about the apex of the heart. So I follow my elbow up and then I measure it there. That's how far it would need to go into the patient. I will then simply lubricate it with some lubricant. And then we want it to run down the left side of the body. So I open the mouth up, I aim it towards the left side of the trachea, and then I insert it down to that pre-measured point. And then I simply hit the start button, and that's going to measure our EKG, or our electric impulses from the heart, and we'll be able to see that on our graph over here. And then we're also getting, like I mentioned, our CO2 reading and then our specific oxygen as well. And then we also have our SpO2 monitor, which is attached to the tongue, a fleshy part of the body that will allow for a good oxygenation reading, which will show up on our monitor over there. So this here is measuring the oxygenation in the blood that's circulating through the body. Anything over 90 is considered good. 98, 99, those are considered the best. When it drops down under 89, we're concerned that the patient isn't getting enough oxygen to the body. From there, we have our blood pressure, like I said, and our blood pressure is reading. We push the button to read it every 5 minutes, and then we will kind of get an average of our blood pressure throughout the surgery to make sure that we're not dropping our blood pressure. What we're going to do to monitor today is we're just taking this form here, and we go down to our time, and we just input our time, and then we're also watching our chart, or our EKG machine in the background. So for 10:36 as the procedure is going on, we go ahead and enter our heart rate, which is at 99. We enter our temperature, which we just took manually, and that was at 102. Our respiratory rate for our pet currently is at 14. And then we go and check their CRT. Our SpO2 currently is at 93. Our ISO percentage, we are currently at a level 2, and then our flow rate is at a 3. Our thermal support is currently off because our temperature is at 102. And then we do this every 5 minutes for the course of the procedure until the intubation time and the surgery stop time, and we'll put those there at the bottom. We will then grab our sponge and start at the finger and scrub 5 times on each surface. And then the palm of the hand, the back of the hand, the sides of the hand, and then the other hand. And then we go down to the wrists and the arms. And then we rinse from the fingertips up to the elbows. And then we take our towel from the fingertips up to the elbows. And then we grab the other side from the fingertips up to the elbows. And then we put on our gown and after our surgical scrub, I am now going to gown up. I remove my gown without letting it hit the floor. And I'm only touching the inside aspect of the gown so as to remain sterile on the outside. I will feed my arms through, not releasing my hands through the cuffs yet. And again on this side, and then I will have someone tie me. So to open, to close glove, I will simply grab my glove with my hands here inside of the cuffs of my gown. I won't actually insert my hands into the gloves or outside of the gown until my hands are in the gloves. And once I have my hands inside the glove, I will adjust my fingers and pull the cuff of the glove down over the sleeve of the gown. And then I will do the same thing to the other side. I will put the glove on and only push my fingers and hand through once the glove is covering the gown, so that no skin is ever outside of the gown or outside of the gloves. And then I will keep my hands in a position between my waist and my shoulders. I have my drapes that have been sterilely opened. I will drape in a quadrant manner. Taking care not to reach over the surgical plane, I'll walk to the other side of the table to lay down the final drape. And then I will continue and finish opening our surgical pack. To organize that and pull out my towel clamps. And with my towel clamps, I will clamp our towel into place. You want to grab a bite of skin so that the towel doesn't move throughout the procedure. To set up and kind of separate all of our instruments in our pack has already been initially opened aseptically from the outside, but this inside part has not been touched, so it's all sterile. I open up this second layer. And I have my gauze in here. We count our gauze to make sure that the appropriate amount is in here. Once we get finished counting our gauze, we will separate all of our instruments. I will take our spade hook out of our instruments, move our top clamps so that when we're ready to drape our patient, they'll be accessible to us. My needle drivers I like to have off to the side, and then our hemostats are all bunched together, as well as our tissue forceps and our scissors.
I apologize that you can't see my right hand in this frame, but what I'm doing with the gauze is I'm blotting some bleeding tissue, and what I'm doing to blot is I'm pouncing the gauze up and down. I'm not rubbing or swiping across the surface as not to damage any tissue and not to break away any clotting. I'm simply dabbing in an up and down motion.
Particular procedures such as bladder stone removal or another type of abdominal surgery where tissues are open to the air and they need to stay moist, we would have our particular moistening set that's autoclaved. So we have a dry lap sponge in our stainless steel sponge bowl, autoclaved appropriately and stored. And then for those procedures, which unfortunately we haven't had one, so I can't show it in real time, we get that out of our closet. And then as a sterile, gowned up assistant assisting our doctor, we would have an unsterile assistant pour in our sterile lactated ringers at an elevation into our bowl. And then from here, we would just simply, I would moisten the tissue. So I'll demonstrate that on how we would do that. But basically, away from the surgical table, we have our lap sponge soaking in our solution of sodium chloride. And then we just bring that over and we would drip that onto the open wound, the open abdomen of the patient. We wouldn't rub or wipe, we would simply allow it to drip on and moisten the tissues so as not to disrupt anything but to keep everything moist and healthy. Of course, this would be in a sterile, scrubbed up nature, but for the sake of this demonstration, we don't have a patient to do that. We had our scalpel blade in our pack, we opened that up and I grabbed a pair of hemostats. I'm simply going to line up these grooves until it snaps into place, and that is a live scalpel. The way that I'll pass the instruments to the doctor, I'm going to be passing them into the palm of his hand. So if he needs hemostats, I'll be grasping them like this and then passing them into the palm of his hand, his outline hand, so that he can immediately just go in and clamp what he needs. And when passing a scalpel blade, you pass with the sharp blade away from your fingers and again into the palm of his hand. So as I pass, that blade doesn't have a chance of coming back and hitting my palm, and it's also not pointed towards him for him to grab. So I, again, with my forefingers and my thumb, pass it into the palm of his hand like that. And that was of a sterile assistant are to maintain sterility first and foremost. So as I'm assisting with a procedure, as I'm grabbing instruments and handing them to the surgeon, and as I'm retracting body parts or tissue, I need to be aware that I need to stay sterile. So I'm not up against the table with my gown pressed to the edge of the table. I'm not dropping my hands. I'm also paying attention to my body. I'm making sure that I'm not about to sneeze. I'm not about to get weak in the knees or get nauseated. I'm not going to pass out during the procedure. I'm keeping aware. I'm keeping sure that I'm going to maintain a safe and sterile environment. Not reaching over but passing things from the side or reaching to the side or going around the entire table. I need to be aware of what is considered sterile. So the front of my gown, my arms need to be staying in between my waist and my shoulder blades. I need to make sure that I'm not having any contact with anything that's unsterile, and that if I need to move around, I'm either side shuffling or I'm turning my back towards anything that's unsterile. Aside from that, just handing the surgeon instruments as needed, being comfortable with the names the surgeon calls the instruments, being familiar with the surgery itself, that I know what steps are next so that I can be prepared for the next thing that the doctor needs. And then also patient care. I need to be aware of the patient and be aware of the field and making sure that there's no wet drapes or wet towels and that there's no strike through going on or contamination, and just overall maintaining the sterility while the surgeon can focus on the procedure itself. To maintain asepsis and orderliness of surgery while being a sterile assistant, my main goal is to be conscious of everything around me. I'm also making sure that when I am assisting and retracting and grabbing instruments, that I'm not doing so in a way that's going to contaminate anything. I'm making sure to do it by the book and to kind of grab and go around and not touch the table. If I'm moistening areas, I'm not moistening the drapes. I'm not getting the drapes wet as to contaminate via strike through. And then from there, I just pay attention. I'm not grabbing something in a manner that's going to rip my glove and cause contamination there. If I do contaminate in any way, or I see contamination in any way, I need to take the steps to fix that. If a glove rips, I need to step away and go and change my gloves or my gown. If I notice that there's strike through on a drape, it needs to be accounted for and discussed with the surgeon on the best route to fix it. As far as if anything falls on the floor, you just let it fall, you don't then pick it up. You use a replacement if you have one. If you need an assistant to flash sterilize something, you have that option as well. Ultimately, it's just my job to keep a conscious mind on asepsis so that the doctor doesn't have to worry about it. Post-surgical cleanup, the first thing we like to do is just make sure our ISO's off, our oxygen's off, and that our anesthesia machine is detached from the wall. At this time, we'll talk about refills a little bit later, but we just take our parts that need to be washed off. Our scalpel blade has already been, as soon as the surgeon's done with the scalpel blade, he hands it to an assistant to take the blade off and throw it in sharp so that nobody gets unintentionally harmed. And then that's already in the drawer in our soaking bucket. And then we'll take the remaining instruments and take all of this out to our sink where it'll be washed. And then anything else that needs to be washed, we have our tie downs, and that's pretty much it for this one. So I take these out to our sink where they're gonna get scrubbed. So that those instruments can now just start their pre-soak, so that by the time I'm done in here, I can just go and scrub those. I take all of our laundry, and then we have some lap sponges down here, but we don't reuse lap sponges, so those are going to go into our separate tissue trash cans. So we have some lap sponges as well as some organs like our ovaries and our testicles that we might take out. Those are all going to be in this bucket. And we have a trash can here with a trash bag that's only for things that needs to be either burned or disposed of properly. So I take all that and put it into that trash can. And then from there, this bucket will get washed along with our laundry. So I like to take that into our laundry room with our bathtub. And then from there, we start talking about equipment and actually cleaning the room itself. I like to get a lint-free towel and spray our cleaner on it and clean off our leads. In between the leads where it attaches to the patient, and then make sure that all of that is untangled and gets wound up appropriately so that it's easy to use next time. And then we just unplug that and put it back in its cabinet. From there, we wipe off our mat on both sides, not just the top, because sometimes underneath it gets dirty as well. But I bring it over to this table when it's off of there because I still need to clean our surgical table. I wipe that side off. And then I go to the surgical table and make sure to pop it up so that I can get inside the grooves here. And then I also take out our drain and I wipe that out. If it was a particularly bloody surgery, I'll actually take it to our bathtub, but just for basic spays and neuters, very little gets in here, so I just spray it with our regular spray and then stick it back in. I also wipe down our lights. Turn those off. You can take off these handles and autoclave them, but we have somebody that positions lights for the doctor, so it doesn't really have to. But we do take those off, clean them, and then screw them back in. And we do that for both lights. charge in for the next procedure. Let me turn that off. And then as far as our anesthetic machine, we just make sure that today didn't go over the amount of hours that's good on our CO2 canister, which we just changed this out so we can leave that. We fill up our ISO, so I don't know if you're able to see this. We just make sure that in this window here, we have enough ISO to reach the filled line. If not, we would unscrew this and then put our ISO into that chamber until it reaches our completely filled line. And then from there, we go and turn off our oxygen in our closet outside of this room. And that's pretty much it. We'll then sweep and mop and do the basics, and then just scrub, autoclave our packs, and then get ready for the next day of surgeries. Once we start cleaning our surgical instruments, the first thing that we do is allow a pre-soak to happen. We usually let it sit for about 30 to 45 minutes or until all of our surgeries are done. And then we come in and we start cleaning. What the pre-soak does, it allows for all the blood and anything that's dried on the instruments to loosen up so that scrubbing off the blood is easier. And it also just kind of moistens the instruments so that anything contamination-wise is a little bit easier to come off. We have our soft bristled brush, nothing abrasive, nothing like wire. The instruments are delicate, so we want to be careful with them while also doing a pretty thorough cleaning. And then what we have in this bucket here is a mixture of warm water as well as our pre-soak. So our instrument cleaner here, we allow that to sit in there at the correct dilution. And then from there, we'll just start to clean after the pre-soak is complete. Now with these two buckets, what I have is just distilled water to rinse the instruments off so that all of the minerals and stuff in our tap water doesn't affect the instruments over time. And then we also have our milk bath, which is our lubricant, and we use a surgical lubricant, and it's 1 part lubricant to 6 parts water. There's also ultrasonic cleaning that we'll touch on. We don't have one set up currently, but that's another way to properly clean our instruments. So I will show kind of our process of cleaning these, and then we will show how to wrap the pack. We want to make sure that we're focusing on the hinges as well as any of the abrasive kind of parts. So I make sure that I clean the ends of the forceps as well as the hinge at the bottom, and then just all around the outside. And then just dunk it into my distilled water to rinse off. And then I'll take it and put it in my surgical milk. Again, you want to open up the hinges and make sure that there's no blood in there. And do a really thorough cleaning. And then the locks at the end, you want to make sure that those are clean, as well as the handles. And then you just continue to clean the instruments one by one, rinsing and then dunking. As soon as all of the instruments are clean, we'll let them just finish soaking in the instrument milk for another couple of minutes, and then we'll allow them to dry on our lint-free towel. Now, when we start talking about our ultrasonic cleaners, in between these steps, so you would still need to kind of rinse off in distilled water, but in our ultrasonic cleaner we would have a mixture of distilled water and then like a cleaning enzyme. And then what the ultrasonic cleaner does is it vibrates or creates like ultrasonic sound waves that create a bubbling effect, and that bubbling effect kind of scrubs the bubbles in a way, or scrubs the instruments to where all of these hinges and all of like the box locks or anything that you can't get to with the brush, it's basically scrubbing all of those. So all of those bubbles are getting in there, and scrubbing. So all of these hinges here, which I can kind of get to with my brush and that I focus a lot on because we don't have the ultrasonic cleaner. The ultrasonic cleaner would get in there better than my brush can. And while yes, I am looking through here and making sure that there's no buildup, an ultrasonic cleaner would take some of that hassle away from me. It's also heated. It's heated from like 100 degrees to 130 degrees. And that just allows the enzymes to be at their most efficient temperature. And that's usually like a 5-minute process. So once you finish up with your ultrasonic cleaning, you can then put all of your instruments into a milk bath to soak for about 5 minutes, and that will lubricate them after the cleaning. So another kind of hinge that you really want to pay attention to here, you just want to get down into all those crevices since we don't have that ultrasonic cleaner, and make sure that they're clear of any debris. And the pre-soak helps a lot with cleaning out hinges that you can't get to with the brush. When we get to the point where we're wrapping our packs, we first go and make sure that all of our utensils are opening and closing properly, that the clamps are staying clamped, that they're not popping open, and that everything is smooth. So with our scissors, we actually make sure that it's a smooth cut that we can feel when we open it up. We make sure that there's no signs of any extra blood or anything that wasn't cleaned off in the scrubbing process. And then we actually line up all of our utensils. So with this pack, it's our large spay pack. So we have not only a spay hook, but we also have 2 sets of scissors, a pair of curved scissors, a pair of straight scissors. We have our needle drivers. We have some tissue forceps. We have all of our regular hemostats, mosquito hemostats, all of the hemostats deemed necessary for this procedure by our doctor. And this is what we would label as our large spay pack. And it's all color-coded as well. And then we have 2 separate types of forceps and our scalpel blade as well. So we put the spay hook through all of the open, unclamped utensils. We put our forceps on one side and our scalpel on the other. And then we count out our gauze pads. We like 20 gauze pads, 10 in each stack, 1, 2. So 10, and then we'll go for 20. So we have 2 stacks of 10 equaling 20 gauze pads. And then we do a double wrap in an envelope style. So with our first wrap, we just wrap it straight. And then we will place this into our kind of at an angle. So I pull this edge of the fold up, and then I pull my sides in so that I'm creating a fold here. And then I take this, and I like to loop it or kind of twist it so that it stays folded nice and tightly. And then when we mark it with our autoclave tape, we mark that it's sealed. So we take a piece of tape long enough to show the seal. If that's taken off or broken, we'll know that it has been opened and that it's no longer sterile. And then we label what the pack is, so our large spay, my initials, and then our date on our autoclave tape. And that's how we would wrap a pack to be autoclaved. Today we're showing how to wrap a surgical gown. So first, after we wash and dry our gown, what we want to try and find is the outside. So all of this outside of the gown is going to be sterile, and that's important to note when you wrap it. So you lay the gown sterile side up on the table because you're going to be folding all of the sterility into itself. You don't want anything sterile on the outside. So you get the sterile side up, and then you fold it inwards. So both sleeves come in, all the ties come in. I fold each side to the center, making sure that there are no loose ties except for the ones at the top. And then you fold it one more time to the center, and then you fold it into itself. And then you start to accordion fold it. so that it's easy to pull apart. And then at the very top, you just want to make sure that the neck piece is available to grab and that these ties are available for you. So if you notice this tag here, this tag's hanging out, and that allows the person to grab at the collar of the inside of the gown to pull it up and let it fall down, and then to stick their arms into the holes. So if I was to pull this straight up, it would fall down and the openings to the holes would be facing me, so I'm able to just hold it and stick one arm in and then stick the other arm in, and the sterile part is on the outside of the gown. And then we'll just take a drape, we'll lay our drape out, and then we like to envelope fold it. And then you apply your sterility autoclave tape to show that it's going to be autoclaved. When we fill and run our autoclave, we have to use distilled water, or else it will start to add extra minerals and build up onto the machine itself and what we're autoclaving inside. So in this reservoir tank, there's a specific line that I need to fill this up to, and that's what I'm going to do now. Once that reservoir tank has the appropriate amount of water in it, I will then pack the autoclave. So I have a tray in here, and what I do with my tray is I put everything just kind of loosely packed. Like, I don't cram it in here. I make sure that there's not a whole lot overlapping, and that everything has room to breathe. And then when I put it in, everything has some room to breathe so that all of the steam gets penetrated. And then I will turn my dial to my fill water. In this particular machine, I'll watch the water come all the way through until this groove that's in this chamber. And once the water reaches that chamber, I will then turn it to our steam position. So all the water's coming towards that groove. And once it hits the groove, I'll shut it, tighten my handle, and turn my knob to the steam position. And then I set a timer for 30 minutes. So it'll steam for 30 minutes, and then it'll air dry for another 15, the extra hot dry for 15 minutes. And then the process will be done. My start button's already started, so that's how we would load an autoclave. Autoclave consists of a couple of different things. Daily, we want to go ahead and just wipe it down. So all this condensation, we want to wipe down with a lid-free cloth. And then if the seal, if there's anything in between the seal, we need to wipe that clean too. You can replace these seals, but we're not doing that quite yet, but these do come out. And then we just take the trays out, we wipe those down. And we usually leave those up here. And then we also wipe down the inside of the chamber. So since there's some condensation in here, it actually aids in cleaning all this dust and dirt and debris out. So we'll just wipe down from the back of it to the front of it. And this is just what we do at the end of the day. Now, aside from just daily maintenance, there's a couple of other things we need to worry about too. We need to make sure that the water in the chamber gets drained once a week to once every 2 weeks. We have a draining valve down here, but we also have a few hoses that we actually siphon it out of. So we'll take that off, put that in there, and then siphon the water out of there too, and then we'll let the remaining flow out of the flow valve. Once we get all the water drained, we kind of clean out the chamber, we refill the water with fresh water. Like I said, we do that like twice every 2 weeks, and then we also use our Chamber Bright Autoclave Cleaner. This you run on a regular cycle, so you fill this up with water, you run this along the bottom or the base of the autoclave, and then you start a cycle without anything in there. You start that cycle, you drain all the water, you refill it, you run another cycle, you drain it, you refill it, and then you're good to go. And we do this once a month on our chamber, or every 20 cycles, kind of depending on how often we're using it. But that's our maintenance on our autoclave.
So we're talking about how the autoclave actually works at this point. I've already showed how to run a cycle, but now we're going to talk about the pressures, the temperature it needs to reach, and then how to tell if something's been autoclaved appropriately. We have our autoclaved instruments and our packs up in the shelf here, and then we have a few unautoclaved items down here just to show for reference. So what we do with our autoclave is we normally put our pouches as well as our packs all in at once if it can fit and there's enough ventilation around it, and we'll just run it at an appropriate for a heavily wrapped pack. So that's up to 30 minutes, usually 15 to 30 minutes at a PSI of about 30, and then the temperature needs to reach at least 270 degrees, and that's pretty average. Now you can autoclave these packs that are just in a little pouch like this, or a flash sterilization of just an instrument itself at a much shorter amount of time. But because we wrap everything and sterilize it at the end of the day, if something like this is in the cycle with something like this, we're gonna do our sterilization temperature and PSI according to our heavily wrapped instruments, and this will just automatically get autoclaved as needed. So our maintenance on the autoclave consists of a couple of different things. Daily, we want to go ahead and just wipe it down. So all this condensation, we want to wipe down with a lid-free cloth. And then if the seal, if there's anything in between the seal, we need to wipe that clean too. You can replace these seals, but we're not doing that quite yet, but these do come out. And then we just take the trays out, we wipe those down, and we usually leave those up here. And then we also wipe down the inside of the chamber. So since there's some condensation in here, it actually aids in cleaning all this dust and dirt and debris out. So we'll just wipe down from the back of it to the front of it. And this is just what we do at the end of the day. Now, aside from just daily maintenance, there's a couple of other things we need to worry about too. We need to make sure that the water in the chamber gets drained once a week to once every 2 weeks. We have a draining valve down here, but we also have a few hoses that we actually siphon it out of. So we'll take that off, put that in there, and then siphon the water out of there too, and then we'll let the remaining flow out of the flow valve. Once we get all the water drained, we kind of clean out the chamber, we refill the water with fresh water. Like I said, we do that like twice every 2 weeks, and then we also use our Chamber Bright Autoclave Cleaner. This you run on a regular cycle, so you fill this up with water, you run this along the bottom or the base of the autoclave, and then you start a cycle without anything in there. You start that cycle, you drain all the water, you refill it, you run another cycle, you drain it, you refill it, and then you're good to go. And we do this once a month on our chamber, or every 20 cycles, kind of depending on how often we're using it. But that's our maintenance on our autoclave. So, like I said before, our pressure gauge is over here on this autoclave. We like to make sure that the pressure is reaching a certain amount and that our temperature is reaching a certain amount. And then we have our time dial, so 15 to 30 minutes depending on the packs that we're wrapping and autoclaving. And then that's kind of how we know that the autoclave is doing its job. There's a fail-safe though, where we have our autoclave tape, and then this sterilization peel roll has markings on it as well. So first of all, our tape. This is a pack that hasn't been autoclaved, and I can see that by the way that the tape is colored. Right off of the roll, it looks exactly the same. When it's under the correct pressure and the correct temperature, it turns dark black. So it turns out looking like this. So as I can see, this is appropriately autoclaved, but that doesn't necessarily mean the contents inside are appropriately autoclaved. Occasionally it's a good idea to add a piece of tape on the inside of a heavy pack to make sure that that temperature and that sterilization and that pressure is hitting the inside of the pack. But if we are gauging it off of the time that it's been into the autoclave, then we know we're doing a good job. So as long as I know that this was autoclaved at an appropriate pressure of 30 psi and an appropriate temperature of 270 degrees, and I know that our tape on the outside is this dark color, then I believe that this has been appropriately sterilized. That being said, we also have these pouches. So with this particular pouch, this color here, this little light red circle, it will turn dark brown as it's been sterilized appropriately. We have one that's been in here, and as you can see, that has changed colors to a dark brown goldy color. So this has been sterilized where this has not, and that's always something you need to check for. And that's how we would know if. We're going to start off by talking about the suture needle itself. The suture needles can come in different forms. So when you think about a needle, you think about a sharp point going to a round body. That would be your traditional taper point. So it's exactly what it sounds like. The entire body of it's circular. It's not shaped like a triangle, it's just a circle, but it comes to a very sharp cutting point. And that point, it allows the suture to easily go through, but the fact that the rest of the needle doesn't have any sharp edges for cutting, then it doesn't cause as much cutting or damage to the tissue. But it also makes it a little bit harder to push through. So you try to push a taper needle through a very tough piece of tissue and it's not going to go very easily because there's no cutting assistance. But it is very good for not causing damage to tissue. So if you have tissue like in your GI system along the small or the large intestine that you need to suture without damage, you need to make sure that that suture line is tight and sealed and the tissue is relatively easy to pierce, then a taper point would work well for that. We also have two other very common needle types here in this clinic. We have a reverse cutting, which is mostly what we use. We actually have 1, 2, 3, 4, 5 reverse cutting needles. And then the reverse cutting is where you have your curved needle, and on that underside of the curve, so what's going into the patient, so the underside of that curve, that is what's actually cutting. So it's allowing you to go through thicker tissue a little bit easier by having that cutting nature. But because the inside of the curve is still smooth, it's not causing damage towards the incision or laceration or whatever we are suturing closed. So it's stable, it allows us to get through that tissue that's a little bit harder to get through, but it doesn't cause any damage to the actual laceration area or the suture area itself. Where the reverse is the opposite with our cutting needles. Our cutting needles are like a right side up triangle where that third cutting edge is actually on the inside of the curve. And when you are actively pushing through that curved needle, that cutting edge is towards the area of tissue damage or trauma or whatever is going on with the patient. And so that in turn can sometimes cause a little bit of damage to the outside tissue. And so sometimes it's a little bit harder to use that needle. But those are the needles that we mostly use in this clinic. When talking about suture type, we first start with the differences in the types of suture themselves. So we initially have a difference in our monofilament versus our multifilament. A monofilament is simply a single strand of a material that's used as a suture, where your multifilament or your braided is where there's multiple strands that are twisted or braided together. Ultimately, these two things matter in the sense of what you're needing the suture for, because there's a few differences with them. The monofilament, what that's going to do is it's going to create less drag, so it makes it easier to move through the tissue. There's less damage to the tissue and less irritation to the tissue. So if that's important, then that's something you need to consider. You also have the fact that your multifilament, where it's braided together, it is higher in capillarity, which is basically a higher chance of microorganisms being inside of that braided, twisted material, whereas your monofilament or your single strand isn't going to have as much of a problem with that. So your multifilament sometimes isn't recommended when you're closing up extremely compromised tissue, because you might be adding in more microorganisms than are already there. There is some coating that you can talk about when you talk about your multifilament. You can coat these multifilament so that there's less of a chance of that happening. But overall, just know that your multifilament is going to have a greater capillarity. And then finally, you have the fact that you have a little bit of give with your multifilament, where your monofilament is a little bit harder to handle usually, meaning your knots that you make, your knots with your braided filament are usually going to stay together easier. There's more to hold on to, there's more of a texture to it. So when you make a knot with your multifilament, it's a stronger knot, it's more likely to retain that shape. Or your monofilament, you might not have as much, it might want to come apart a little bit easier because there's nothing to grab onto, there's none of that texture to hold onto. So your monofilament's a little bit more like fishing wire, which is kind of hard to tie a knot with, where your multifilament is more like a rope, which is a little bit easier to tie a knot with. It's more sturdy, it's more stable, there's a little bit more memory. So from there you also have your absorbable and your non-absorbable. You can have both of either. You can have a multifilament absorbable, a multifilament non-absorbable, and the same with your other types of suture. So with your absorbable versus your non-absorbable, what you really want to know is where you need the suture to stay and how long you need it to be there. Your tensile strength, or the strength of that
suture to hold those tissues together, you need to figure out how long you need those tissues to be held together by an outside object. If those tissues after 60 days are not strong enough to hold together on their own, then you probably need a non-absorbable suture. Whereas your absorbable suture, if those tissues heal very easily and very quickly within 60 days, and you can take that suture out and they would hold together well, then you can use your non-absorbable or your absorbable suture. You also think about where you're going to be putting this. Your non-absorbable suture you usually put underneath the skin to close buried incisions because you can't then go in and take them out and they need to dissolve on their own. Whereas your non-absorbable you can put on the outside where you close up a wound, especially if you need it to stay closed for a long period of time. And so that's kind of where you would use those different types. And then from there we have our sizes. The sizes of our different types of suture are dependent on, again, where you're putting them. So we have everything from our 2-aught, 3-aught, 4-aught, and 5-aught. Our 2-aught is going to be the biggest size that we carry here, and that is going to be basically the smaller the number, the larger the size. So if you have 5-aught, that means you have 5 zeros, and that's going to be your smallest surgical suture. And then your 2-aught is going to be the largest one that we carry here, but it goes up from there. I mean, you can have much larger suture. Our continuous patterns are usually used when the doctor likes to create some speed or there's a longer incision that's necessary to close. So without cutting and resuturing and tying, it makes the process a little bit faster for those longer incisions. One of the most common is the simple continuous. That's where there's a knot at each end and then it loops around the incision. This creates a really nice airtight seal, and it's very common in surgical procedures here at our clinic. From there you have the Limbert, which is another one that's common for us, but only when we're using it on like a urinary bladder. We use it a lot with our stone removals. That is actually inverting everything, but it is continuous. And then from there you have a few others. The Ford interlocking is used more in large animal. We don't use that much here. And you can also do the horizontal mattress continuous, but often that one's actually interrupted. Those are a few of the continuous. When we come to the interrupted suture type, or the suture patterns, we like to use the simple interrupted the most. It's a very quick and easy suture to place, especially on our small areas. So our spays that we usually do a simple interrupted, and it usually just takes 1 or 2 to close that tiny incision. So it's done quickly, it looks clean, but you have to make sure that the tissue itself is positional rather than being pulled too tightly and inverted, because wound closure at that point is a little bit more difficult. So the proper placement and making sure that it's not too tight is important. However, the disadvantages with this simple interrupted pattern are that it's time consuming, especially if you're using it on a large portion. We recently did simple continuous on a large tear that occurred on the dorsal part of a golden retriever. It was about 12 to 15 inches long, and that simple continuous took a while. It helped with wound healing a lot, and it was a good suture to use, especially since we were also adding in Penrose drains due to the area of dead space that this wound caused. But it did take a while to do that. So that's one of the downfalls, but it is a very strong and reliable suture. We have the horizontal and the vertical mattress. When we're talking about interrupted suture pattern, the horizontal mattress suture pattern is a lot like the simple continuous. It's just a different pattern, but it's kind of used the same way. There's a chance that if the tissue is not lined up appropriately, that wound healing is going to be a little bit harder for the patient, and it's still time consuming. Whereas with our vertical mattress interrupted pattern, there's a little bit more give. The strength of the vertical mattress suture placement or suture pattern is that it is very strong, and it also is used in areas of high tension, because if that tension on the suture is too tight, it doesn't invert like some of our other interrupted sutures. And so it's good for those areas where you're worried about unintentional inverting. So to remove these sutures, what I'm going to do is simply pull out at where they were inserted. Then make a quick snip at the loop, and it pulls out as one final suture. And this incision site is completely healed up with no signs of infection or irritation. When determining if sutures are ready to come out of a patient, you initially look at the overall appearance of the incision. So you want to make sure that there's no redness or irritation, there's no discharge, and that the incision itself looks healed up. Basically, if you remove these sutures too early and that incision is not holding itself together on its own, then it could potentially come apart. So you're looking for any signs of active infection. You're looking to make sure that it's been long enough and that this particular area of the body is healed up appropriately before removing those sutures. You also want to feel the incision if there's heat, extreme heat that's coming off of it. That's another sign of infection. And then you also want to take the pet's temperature to make sure that they're not fighting an infection that can't easily be seen. Those are a few of the ways that you would decide if sutures are ready to come out at a particular time.